Hello everyone. So unfortunately, I just finished recording a whole 20-minute video, me explaining the topic, but unfortunately there's no voice in the video. My mic wasn't working for some reason, but it's fine. You should always say Alhamdulillah about anything that happens in your life. Maybe I'll take this opportunity to learn more about the topic, study it again, and maybe present it better for you. So let's begin. Today, hello everyone. Should I say the intro or no? Let's say it. Hello everyone. Today we'll speak about bronchial asthma in children. So let's begin. What is asthma? Asthma. Oh, just let me do something cool. I learned. Yes, laser. What is asthma? Asthma causes respiratory symptoms such as wheezing, shortness of breath, chest tightening, and cough that vary over time, including in their frequency and intensity. These symptoms are associated with a variable expiratory airflow limitations such as difficulty breathing air out of the lung due to the bronchoconstriction. This asthma have a different types, and we call them phenotypes, and they are differing from the underlying disease processes. Factors that may trigger or worsen asthma symptoms. First of all, viral infections, allergens at home or work, such as the house dust, mite, cockroaches, tobacco smoke, exercise, and stress. These responses are more likely when asthma is uncontrolled. Uncontrolled asthma is when we are not controlling the asthma properly. Maybe the drugs are not working for us. Maybe we are taking drugs for another severity for the asthma. Maybe the patient is just ignoring the maintenance dosage of the drug every day, so it's uncontrolled. Asthma can be also induced by some medications such as beta blockers and in some patients aspirin and NSAIDs. For example, beta blockers have a bronchodilation effect actually, but when the beta receptors are blocked, they will do a bronchoconstriction effect instead, so we will have a worsening of our asthma symptoms. So, let's speak about asthma flare-ups, which is also known as exacerbations or attacks. It's when it can be fatal, of course, so it's really important to know about it. So, it's when we will have a very severe symptoms of asthma, it's like an attack of asthma. This can even happen in mild asthma. It usually happens more in severe asthma or when the asthma is uncontrolled. That's why every patient should have a written asthma action plan, which is a paper or anything that they will have like a steps to what to do when this happens so it won't be fatal. ICS means inhalated corticosteroids. Continuing treatment are really good for treating asthma because they will reduce the frequency and severity of the asthma symptoms. Asthma treatment should be customized for the individual patient because we know patients have different level of symptoms, different risk factors, different phenotype or characteristics of asthma, different preferences for the treatment, different effectiveness, and maybe the cost is also important for some patients. Making a diagnosis of asthma. Asthma is a disease with many variations, usually characterized by chronic airway inflammation. So, a history of respiratory symptoms like wheezing, short of breath, chest tightening, and cough is important. They will do other tests to confirm the diagnosis of asthma, such as spirometry, and we'll talk about this later. Physical examination is usually normal, but sometimes we can see wheezing in auscultation, especially in forced expiration. Forced expiration is when we tell the patient to force his breathing. It's not like he's breathing normal, tell him force the expiration. I'll try to demonstrate it. We'll make him expire more air. So this is the diagnostic flow chart for asthma. It's really beautiful. It's from the China guidelines. I will leave the link in the description if you want to read the whole book. Or I don't know if we should call it a book. It's about 50 pages, I think. It's really beautiful. It's amazing. So, first of all, we'll have patient with respiratory symptoms. So we'll see, are these symptoms typical for asthma? Are they cough, shortness of breath, tightening of breathing, cough? If they are, we will go to the next step. If no, we'll try to find an alternative diagnosis. Then we'll take a detailed history and examination of the patient. Examination. We'll do a spirometry test. We will do auscultation. Maybe we'll hear wheezing. We'll take a detailed history. When the symptoms get worse at night, yes. Do you have these symptoms when you wake up? Do you have these symptoms when you walk or do any exercise? Does anyone of your family have asthma or any allergies? If it's yes and it supports the asthma diagnosis, we go to the next step, which is the patient already taking ICS or no? If no, we'll go to the next. If yes, that means the drug is not working. Maybe we should change the drug. Maybe we should add the drug. Maybe we should do something. So, if no, we will do a spirometry with a reversibility test. We'll talk about the reversibility test a minute from now, I think. So, let's not talk about it now. If we got the results supports asthma, we'll treat it off as asthma. If no, we'll do other tests, and if it confirms asthma, we'll give him a treatment. If no, we will consider trial treatment for the most likely diagnosis until we do further examinations. Pretty easy, pretty nice. So, confirming the diagnosis, we'll do a spirometry. And the spirometry, we will have FIV1, which is forced expiratory volume, and we will have also the FIV1 to FVC ratio. They will both get reduced when we do a spirometry. So these are the normal readings for it. For young children, is more than 80%. When the ratio is 85 to 90%. Adolescents, the FIV1 is also 80%, and the ratio is 80 to 85%. So let's talk a little bit about other things like labs and things before we speak about the spirometry test. So for the physical examination findings, we will see using for accessory muscles or no and nasal flaring. For auscultation, we will hear wheezing, usually expiratory wheezing, and it could be inspiratory as well. It could be audible without auscultation, even. Different severities, and a prolonged expiratory phase. For the percussion, it's usually normal. Sometimes we can get hyperresonance. Lab test CBC may show eosinophilia, in one case an allergic asthma, but it's not diagnostic. And we can do allergic testing, skin break for serum IgE, immunoglobulin E, if allergic trigger is suspected. Instrumental study, spirometry, we'll talk about it later. Peak expiratory flow, which is this thing. We will make the patient blow here and we'll see the reading and we see how good is his lung working. Chest x-ray is usually normal, but we'll maybe do it for, what do you call it, rule out the differentials. Expected results. For spirometry, we'll have a reduced FIV1 and FIV1 to FVC ratio, and it will improve after the bronchodilators, which is the reversibility test. We will talk about it now, I believe. Yes, we will talk about it. But first of all, a history of variable respiratory symptoms. This one is criteria for making the diagnosis of for asthma. So typical symptoms are wheezing, shortness of breath, chest tightening, cough. This is the fourth time I say this. And yes, don't forget to like and hi. So the patient should have more than one of these symptoms. They will get worse at night or when waking up. It will get triggered by exercise, laughing, or allergies or cold air. It will worsen with a viral infection. Then we will do the spirometry reversible test. So we'll take the reading of the spirometry, FIV1 and FIV1 to the FIV1 other ratio. We will see that they are reduced. Then we will give them a bronchodilator drug, and we will should expect an increase in the FIV1 in the percentage of 12%, which is 200 milliliter, and the BEF variability will increase in 30%. Also, the ratio will increase, but I don't remember the exact number, so I think I didn't include it here. So this is a very beautiful chart speaking about the criteria to speak about the. So this is a very beautiful chart speaking about the criteria for determining the severity of the asthma. So first of all, we'll see if the suprasternal drawing is present. If it's not, zero present too. If we will see also use for accessory muscles, absent zero, present two. Wheezing, absent is zero, expiratory only is one, both is two, and audible without auscultation is three. Air entry, normal zero, decrease at the basis one, wide separate two, absent on minimum three, and for the Oxygen saturations as well. We have some certain levels, and we will determine the number, the score. Mild is 0 to 4, moderate is 5 to 8, and severe is 9 to 12. Now, how to assess a patient with asthma, like his asthma control? So for the asthma control, we'll do it for the past 4 weeks and see how the outcome of it. We'll also assess the multimorbidity, all these diseases that are present here. Stop the video and read them because they may affect the asthma. And we see the treatment issues. We ask the patient, do you experience any side effects from it? So show me how to use your inhaler because the technique may be wrong. I'm sure you all saw the video of Dr. House when the lady was using his inhaler on her neck. And check if he have the written asthma action plan for the emergencies. And we'll ask him about his preferences for the asthma treatments. Now we will do an assessment for the symptom control. We have a yes and no questions. Daytime symptoms more than twice a week? Yes, no. Any night waking due to asthma? Yes, no. SABA reliever needed more than twice a week? Yes, no. Any activity limitation due to asthma? Yes, no. 0 is well controlled. 1 to 2 is partial controlled. 3 to 4 is not controlled. Now, let's speak about the risk factor for poor asthma outcomes. This will be boring to read, but I hope you will, what you call it, you'll stand with me. Preterm birth, low birth weight, greater infant weight gain, chronic mucus hypersecretion, lack of ICS in patients with history of severe exacerbation, nauseous or written exposures like tobacco smoke, chemicals, occupational or domestic exposures. Yes, it was boring. We spoke about this about 10 times till now, so if you just want to revise it, stop the video and read it. Now, here we will just speak how good is the inhaling corticosteroids. So, even patients with mild asthma can have severe exacerbations, we said that. Low dose ICS can reduce the asthma, death, and hospitalization. It's effective in preventing more exacerbations. It reduces the symptoms. Early treatment with it can give us better lung function, and not taking it will give us an increase in the severity of the exacerbation. How cool it is! Amazing drug. So, sub-only treatment was used like 50 years ago. It's not written here, I read it somewhere in the book. So, China does not recommend treatment with asthma with sabo only. Why? It's also not written here because I think I deleted the picture by mistake. So, why? Because it will increase the frequency of the exacerbations. So, now we'll speak about the treatment. This is for the adolescents, which is more than 12 years. So, let's just skip this one and see this beautiful picture. This will be boring also, but there's no other solution. So if the patient is experiencing symptoms less than 4 to 5 days a week, so we will just give him a low dose ICS. If the symptoms are most days or waking with asthma once a week or more, we'll give him a low dose maintenance ICS. Maintenance means that we will give him every day this dose, even if he doesn't have the symptoms. Daily symptoms or waking up with asthma once a week or more with a low lung function, we give him medium dose maintenance ICS, like for example, formoterol. And this is for the very severe. We'll give LAMA as well as phenotypic assessment to give him right drugs. Here we have like two, what do you call it, tracks. They will both work, but have some differences. Maybe just stop the video and read them because it's boring to read them. I'm sure you all skipped me reading them and you just stop the video and read them. I am epic. Next, now we'll speak about children 6 to 11 years. So, symptoms less than twice a month, we give them a low dose ICS. Symptoms twice a month or more, we'll give them a daily dose of health corticosteroids. Low dose. Symptoms most days or waking up with asthma once a week or more, low dose ICS with LABA or medium dose ICS. We can choose. Symptoms most days or waking up with asthma once a week or more and low lung function, medium dose ICS with LABA or low dose ICS. And if it's so severe, we should see the phenotypic and assist. Here you can stop the video and read it. It's the preferred doses of the ICS in different cases. It's actually really good to have this picture. And finally, patient education and prevention. This is for the infants, like what do you call them? The newborns, I think. Avoid exposure to tobacco smoke, encourage breastfeeding and proper nutrition, ensure up to date vaccination, regular monitoring of symptoms, patient and caregiver education about the early signs of exacerbation, development of written asthma action plan, including when to adjust medications, regular activity according to the child ability, and educate families about managing what they call it, common triggers and maintaining healthy home environment. So that's all. Thank you so much for watching. I hope you liked the video. You found it useful. I will leave the China book in the description if you want to get more information. Don't forget to like or maybe comment so I can see that this actually helps someone. And have a great day. Goodbye.